Hello, everyone. Welcome to Emory's virtual retina interview session. My name is Joan Yan. I'm the director for the Surgical Retina Fellowship. Along with my colleagues who are here with me on a Zoom window, please wave everybody. I would like to give you an introduction of the Emory Retina Fellowship Program, and you won't be quizzed on this later, so please just sit back and enjoy. These slides showcase the great work we are doing at Emory. Dr. Hubbard and our proud Retina Conference series, Dr. Ye and his famous Ebola team, and our top-ranked ophthalmology residency program, and of course, the great city of Atlanta. Emory's Retina Fellowship is a strong tradition here. We've trained over 50 fellows since 1980. Clinical and surgical training is our top priority, as well as research and teaching. We serve a diverse patient population with a population of 5 to 6 million people in the metro Atlanta area. This is a tertiary referral center for the entire southeastern United States. These slides showcase our leadership team. Dr. Alan Beck is our chairman, leading our department through the challenging times because of COVID. Coming from Emory's residency and fellowship, he understands the importance of medical education, is a strong advocate. Dr. Hubbard here is our retina service chief, who holds all of us together like a concentric force. He will be celebrating his 20th year at Emory very soon. So here, Dr. Hubbard, I would like to ask you a question. You were an Emory resident and came back to join the faculty after your surgical fellowship. What brought you back? What can you tell us about the retina faculty at Emory? And what is your vision for our retina fellows?
Joan, well, thanks for putting together this program. And I just want to welcome all the prospective fellows to come visit with us and have a look at the Emory program. I've been around Emory now since I started my residency in 1995, and it's a wonderful place. I've spent my whole career here, in addition to doing my residency here. So I was a resident from 95 to 98, and then went off and did a fellowship at WashU in St. Louis, and came back and joined the faculty in 2000. So as of July of this year, I officially celebrated my 20 years here at Emory, and it's been great. You know, why did I come back? Well, you know, I dreamed of coming back, and I was so fortunate there was an opportunity to come back when I finished my training. And I think the thing that makes it so special is that is, for me at least, is the culture of training that's embedded in our program. And I think it all goes back to Tom Auberg. Tom Auberg was a very special person. He was a wonderful physician. He was a consummate retina surgeon and helped really innovate the field of retina surgery, and was one of the founding innovators for vitrectomy. But the main thing that made him special was the way he interacted with people, and the way he really created a culture of training here at Emory. And it was something that just really inspired me from my very earliest times. And you know, he was surrounded by good people. He was, you know, Dan Martin, Paul Sternberg, Tony Capone, which have all gone on to do great things after leaving Emory and have kind of taken a part of that culture with them. And so for me, the most important thing about our retina service is to maintain this culture of excellent clinical care, but really as important is this culture of training and working with young people and making sure that they learn what they need to learn to go out and do great things in our field. And that inspired me from the beginning, and I hope I get to continue to carry that mission forward.
Well said. Thank you, Dr. Hubbard. So here, since you won't be able to visit us in person, I thought I would include a slide showing the Emory Clinic, which is actually misleading somewhat because the clinic never looks this empty, not even during the COVID lockdown. But this is kind of gives you an overall idea of what the clinic looks like inside. And this slide shows our wonderful new hospital. It is connected to the Emory Eye Center, so that looks pretty nice. All right, here's our Grady team. So Dr. Hendrick, you've been a steward for our fellow training at the Grady Memorial Hospital. Can you tell us more about the Grady experience for fellows? Why is Grady so important for our fellows?
Well, thank you, Joan. Also, welcome and thank you to the candidates taking their time to explore the Emory Vitreoretinal Fellowship training. The experience at Grady is a valuable asset for our retina fellows in several ways. First, it provides fellows in a supervisory role over the residents directing patient care. It may be their first time in a formal teaching role or even conducting medical decision-making, which requires some adjustments to the changes in responsibility. In the clinic, the fellows work in parallel with me and grow into this role as I assist with more difficult decision-making or surgical decision-making. Secondly, this is a vast surgical experience that has an abundance of exposure to complex diabetic membrane dissections and secondary repair of ocular trauma. Of course, we also manage retinal detachment repair and the less common macular holes at this location. And our volume is only limited by how many cases the fellow can perform in a day. Typically, we'll average around 5 per week. In addition to the clinic and surgical experience, I also include public service as an important facet to appeal to our potential candidates. Many candidates are highly interested in community engagement or international ophthalmology for the betterment of our profession. I have confidence that what we do at Grady is critical for the community in a way that I derive great satisfaction, and I'm sure that the candidate would too if they match with us. In summary, Grady is an outstanding asset for our vitreoretinal fellows that permits a graduated approach to professional growth in a supervised fashion that only a few other programs nationwide can rival. Thank you for considering us, and feel free to engage me with further questions during the interview. Thank you, Joan.
Thank you. Thank you, Dr. Hendrick. And here's Dr. Rao, who's also a Grady attending. She joined us a few years ago and it has been a great help. Preeti, how long have you been here with us now?
It's been now about a little over 2 years. So it's been,
My goodness.
yep. So it's been a great experience working with all the faculty. That's one of the main reasons why I wanted to, join Emory.
Wonderful. Thank you. And here's just a great picture of our Grady front entrance. And it's one of the busiest level 1 trauma center in the nation. Has a full capacity, run an OR in a clinic, and it has a ROP screening program going. This looks really nice from the outside. Here comes our great VA team, which is headed by Dr. Blaine Cripps. Dr. Cripps, the Atlanta VA Medical Center has been a long-standing retina fellow training site for us. You've been a director there for many years now, overseeing a tremendous growth in clinic volume. Can you tell us about the VA experience for our fellows?
Thanks, Joan. I'd love to. Let me show you our candidates a brief
I'll stop
presentation.
share.
The VAMC at Atlanta Retina Clinic is a great opportunity for the fellows as well. Similar to like Dr. Hendrick mentioned about the Grady Clinic, one of the great benefits of rotating through the VA clinic is the ability to interact with our stellar residents. A benefit to the VA Atlanta Retina Clinic is it's just on the other side of the woods here from Emory. It's only a short 30-minute walk if you want to walk it, and an 8-minute drive. The best benefits of our VA Retina Clinic is the faculty. We have both full-time and part-time faculty at the VA. Myself, Dr. Patel is there full-time, Dr. Neeraj Jain, and Dr. Rachel Shaw. And there is retina care happening every day at the Atlanta VA, but our fellows experience is limited just to Thursdays. Although, if the opportunity arises, like I said, we've got retina care happening every day. We do have about 18,000 retina specialty visits per year at the Atlanta VA. Currently, we have our surgical retina fellows rotate during their second year from July to December, and during their first year from January until June. Thursday mornings will be in the operating room, and unlike Grady, we can only manage about 1 to 2 cases per week due to just access. Our OR is being shared by the rest of the ophthalmology service and other services. But there are great opportunities in the OR for resident teaching by the fellows. And then Thursday afternoons, we are in the resident retina clinic, where we're typically seeing prior to COVID about 35 to 50 patients a day, in a half day. And that's in conjunction with 2 to 3 senior residents, 2 PGY3s, and 1 first year resident. Our fellows supervise, and if the clinic is busy, sometimes they're seeing patients on their own. In the operating room at the VA, we're using 25 gauge Alcon systems exclusively, and we're still using an Oculus viewing system. We're currently using the Biome Ready disposable system with their HD lens. We have a full diagnostic suite with full-time photographers at the VA, including Cirrus, Heidelberg, and traditional fundus photography. We have the Zeiss Forum viewing system for comparing Cirrus scans over time, which is a really great help when you're talking about macular disease. We see a lot of interesting pathology, both the severe tractional detachments, very interesting retinal dystrophies, vitreoretinal pathologies, tumors, and vascular disease. So it really is a great opportunity for our retina fellows, and I really look forward to seeing all of our candidates and giving them an opportunity to share in this experience.
Well, thank you so much, Dr. Cribbs. That was quite a treat. I learned a lot myself, actually. Moving on next, Dr. Ye. Uveitis training is a strong Emory tradition going back to the days when I was a resident here. Why do you think that is? Can you give us a brief introduction of the Emory Uveitis and Medical Retina Service?
Yeah, thanks, Joan, for the opportunity to talk a little bit about our service. And even when I was interviewing for residency and fellowship, I remember thinking about all the infectious pathology that's offered at Emory, and I think that I've really found that to be true. And so really, I think that is one of the hallmarks of disease processes that we see both at Emory, the Grady, and the VA. So I really appreciate the chance to share with you a little bit about our uveitis program and how we integrate this with medical retina and also the surgical training as well. And I'd like to echo Andy's comments that we really appreciate everybody taking the opportunity to join us this really unusual interview season. So this is our virtual presentation for you. So, without further ado, it's really a privilege to work with 4 wonderful physicians and surgeons, Dr. Purnima Patel and Dr. Rachel Shah, head up our VA uveitis service, and as well as medical retina. We really have diverse training backgrounds. Dr. Ghazala O'Keefe and Dr. Purnima Patel both trained at Doheny in medical retina and uveitis, and really do some fantastic clinical work in these areas. Dr. Jessica Shanta is a NIH K23 awardee and is on a career development award, and has training at the UCSF Proctor Foundation. And we're really lucky that we recruited Rachel to stay on with us at the Emory Eye Center to also practice uveitis and medical retina as well. And they really form the cornerstones of our uveitis and vasculitis service that we're privileged to be a part of. And so really what we seek to do on the uveitis service is we really think about how these uveitis syndromes may have immediate vision-threatening consequences if not recognized and treated. And this really spans a number of disease pathologies ranging from both infectious disease as well as non-infectious pathologies. We also think about uveitis masquerade syndromes that are important to recognize as well. And we really have United States domestic and international portfolios related to Ebola virus disease, as well as the infectious pathologies that we see in the United States. And so I'll just show you some of our bread and butter cases that we manage. These seem to come in July when the first year retina fellows are getting started. And so we hope that some of you will be joining us as well. But this is a young man. He was a 29-year-old male patient, really great young man, but unfortunately had developed acute retinal necrosis. He was actually treated on the outside with Predforte, but as you can see, he requires really a lot more than that in terms of treatment. He also required combination systemic and intravitreal antiviral therapy for his herpetic acute retinal necrosis. And I think that our patient population, for some reason, is enriched for these types of infectious pathologies that really lend themselves to both clinical care as well as research and educational endeavors. This is an individual who was diagnosed by my wonderful colleague, Dr. Pratima Patel. Pratima, you'll remember this, this lady came in, I think usually it's a Friday afternoon at 4 p.m., but she unfortunately had developed Candida in the back of her throat. She had oral thrush, and she actually had a new diagnosis of HIV positivity with this diagnosis of varicella zoster virus associated progressive outer retinal necrosis. And these are the types of conditions that the fellows will be able to manage on a regular basis with our residents and also with our attendings as well. So beyond the infectious pathologies, we also manage a range of severe non-infectious pathology as well. This was a teenage patient who we've managed very recently. She presented with acute vision loss. She had a known diagnosis of systemic lupus and also had a diagnosis of renal disease in association with lupus. And you can see from her fundus photograph that she has these areas of ischemia with these cotton wool spots in the parapapillary location, as well as retinal hemorrhage, severe vascular sheathing. But really the fundus photographs don't do this justice in terms of how ischemic she really was. You can see that she has widespread both retinal and choroidal ischemia throughout her fundus, and she was admitted for aggressive therapy with IV corticosteroids, Cytoxan, in conjunction with our pediatric rheumatologist. And she's done well from an inflammation standpoint and has been transitioned to oral prednisone and CellCept as well. And so alongside the infectious pathologies, you also get a sense for how we manage patients with immunosuppressive therapy as well. But unfortunately, we're in a new age right now in the pandemic, and she missed her appointment on one of her follow-up visits due to COVID-19. And you can see that here she's developed this severe vitreous hemorrhage with this combined tractional and rhegmatogenous retinal detachment. We ended up taking her to the operating room and treated her with a scleral buckle, vitrectomy, membrane peel, and she's had a nice postoperative result. But really beyond this, a nice postoperative result that we see, it really is important to think about these patients very holistically from the standpoint of their systemic immunosuppression. How do we think about their systemic disease and other disease consequences of their disease process? And beyond these infectious and non-infectious pathologies, again, I mentioned these masquerade syndromes. We always have to think about vitreoretinal lymphoma. These are just some examples of patients that we've taken care of very recently with vitreoretinal lymphoma. This individual here had a phenotype that was similar to acute retinal necrosis, but with a vitrectomy, she actually was found to have vitreous involvement with her lymphoma. And we're also involved in a variety of research projects as well. We've had a leadership role in the phase 3 Peachtree study, which was a randomized multi-center trial looking at suprachoroidal drug delivery for the treatment of macular edema due to non-infectious uveitis. It showed very favorable efficacy as well as safety signals. And again, we've had a leadership role. Dr. Andy Hendrick also was a principal investigator of a trial looking at suprachoroidal drug delivery for retinal vein occlusions. And so we're involved in a number of clinical trials as well as investigator-initiated trials as well. And so really, as Baker and Joan have mentioned, Emory offers a broad training in the care of patients with both infectious and non-infectious uveitis. There's a variety of research projects that are ongoing related to drug development and therapies for uveitis and vasculitis. And I think beyond that, what we really want to do is promote your career development from the standpoint of what we can offer as mentors with related to these disease processes. So it really is great to hopefully meet all of you for the remainder of this morning as we go through the interview process. And as I mentioned, we have really great collaborators on the uveitis service, and on the call we have Pratima, Rachel, and Jessica. Would y'all like to just say a few words about your thoughts on the uveitis fellowship and the experience of the various institutions?
Thanks, Steve, and thanks, Joan, for organizing this. Thank you to all the applicants that are interested in our program. We clearly have a wide breadth and depth of pathology. Uveitis is another one of the feathers in our cap. We're very lucky at Emory that we have strong collaboration with rheumatology, pediatric rheumatology, as well as infectious disease and caring for a lot of these complex patients. We have had for the last several years a combined clinic where a rheumatologist comes to the VA to see our uveitis patients. So that's a really nice experience that I did not have in my fellowship, and it's really been an asset in caring for these complex patients. I do this with Rachel at the VA, but we all share the uveitis patients in all of our satellite clinics that we go to, as well as the main Emory clinic where the fellows are.
Thank you. That was fantastic.
Thanks, Joan.
Our retinal degeneration unit comprises of Dr. Neeraj Jain and me. And Dr. Jain, since you came to Emory, you have brought our retinal degeneration service to a new level, and I'm so thankful that you're here. Between two of us, I think we've got 4 to 5 surrounding southeastern states covered. Can you tell us the direction of the retinal degeneration unit and some of the exciting clinical trials that we're working on?
Yeah, sure, Joan. And thanks for the intro. And really feel bad that we don't get to meet you all in person. But I think that it's been a real privilege for me to join Dr. Yan here. And we do indeed have a lot of exciting things in the pipeline. And I think it's important first to recognize how important it is we feel that our trainees kind of gain some basic understandings of ophthalmic genetics. When I did my vitreoretinal fellowship, I hadn't planned on going into ophthalmic genetics, and the IRD specialists were kind of always they didn't really get the attention of the trainees. And I had an eye-opening experience, and it was during my VR fellowship that I actually decided to do a second fellowship out in Portland. And it's really been it was really kind of made my career special. And I think because a lot of us, we have dual training in our subspecialties such as genetics or uveitis, as well as medical retina or surgical retina, I think we can kind of grasp what a VR trainee really needs to learn, so we don't get too much into the weeds on some of the esoteric details. I want to go through briefly a slideshow of some myths amongst VR trainees about ophthalmic genetics. So the first myth, there's nothing you can do for hereditary disease. And in this case, we see a patient with a kind of a striking abnormality of fundus autofluorescence in the posterior pole. And this is a patient who initially we had thought had a pattern dystrophy or some other macular dystrophy. And having training background in both general retina and hereditary diseases, we came up with this diagnosis of Elmeron maculopathy. And many of you have heard of this or will hear of this. And I think it was being able to see things from the perspective of a VR specialist and an ophthalmic geneticist that helped make that diagnosis. The second myth is that there's no surgery, and this is changing quite a bit. And here's a patient who had an epiretinal prosthesis implanted by Dr. Yan, who was formed one of the Argus Centers of Excellence here at Emory. And Dr. Yan has a long history of involvement in some cutting edge clinical trials for hereditary disease, especially with prostheses. She was, I believe, one of the original investigators when the Argus technology was first being developed. This is a wide field montage, and here's an OCT showing the implant sitting on the retina. The third myth is that inherited retinal diseases involves a different skill set that VR trainees don't need to be familiar with. And the truth is there's a lot of overlap. And I think that by exposing our trainees to inherited retinal diseases, you do gain a different appreciation for how to interpret some of the fundus imaging and how to appreciate nuances in different phenotypes of unusual retinal diseases. Here's a patient with a choroidal degeneration. This is a 13-year-old male, and it's an X-linked process called choroideremia. And if you look closely at the left eye, you see whitish appearing material. And when you get the OCT, we see something that our VR trainees are very familiar with. And actually, traditionally, ophthalmic geneticists were not as familiar with this type of presentation. And what we see is this hyperreflective material under the retina that we diagnose with as choroidal neovascularization. This patient underwent anti-VEGF therapy, and 18 months later, there was less intraretinal fluid, but it's not completely gone after many injections. And this is where your expertise as someone with strong vitreoretinal training really would come in handy for a case like this. How do you decide whether or not to continue treatment? A person who's only trained in ophthalmic genetics would not be familiar with this type of disease process. The interesting thing about this case is we took a closer look at the fundus autofluorescence imaging, and what you can see here is this patient has some islands of spared or intact or relatively intact retinal pigment epithelium with scalloped margins in both eyes. And in the left eye, you see some abnormality here. This is where the choroidal neovascular membrane is. And again, this is at the baseline imaging. And then 18 months later, we see changes in the autofluorescence pattern. And we went back and we quantified the amount of intact retinal pigment epithelium we had in the macula here. And it was quite striking to us that the eye that received a lot of anti-VEGF treatments had more significant decline in the island of RPE, of intact RPE. As some of you know, there's an ongoing debate of whether or not long-term VEGF suppression may lead to progression of geographic atrophy. And here's a case that's in the inherited retinal disease world that could have pretty fascinating implications for a bread and butter retinal disease such as AMD. And then as a vitreoretinal specialist or medical retina specialist, then it's up to you to decide again, how are you going to treat this? One other thing I'll point out is the question of what's contained in this scar-like lesion. Well, we did an OCT angiogram and we found this large choroidal neovascular complex. So last case I'll show the myth for, it's all about inherited retinal diseases. Well, this is a 72-year-old male with vision loss over 2 years. This is a fundus photo, and here's an OCT image. And again, I think having experience with the inherited retinal diseases and general retina, you begin to appreciate some of the nuances in this unique imaging phenotypes. In this particular OCT, you'll notice these outer retinal bands are present, but don't look exactly normal. And as you go to the peripheral macula, these outer retinal bands taper off. Here you have this classic parafoveal hyperautofluorescent ring. And we did an extensive evaluation, including sending anti-retinal antibodies, which were positive. In this patient who had had symptoms for some time, we ended up being concerned about cancer-associated retinopathy. And on a PET CT scan, we found a lesion that biopsied as non-small cell lung cancer. So this is the type of thing that I think someone who just does ophthalmic genetics may not be completely familiar with, or someone who hasn't had sufficient training in that during their vitreoretinal training might also not be that familiar with. But I think here at Emory, you get such depth and breadth of training across different disciplines that you'll be well equipped to handle something like this. And truthfully speaking, even in my shoes, I lean heavily on our uveitis service, Steve, Jessica, Ghazala, and Purnima, to be able to handle some of these unusual autoimmune type retinal degenerations. Well, thanks for your time, and look forward to the virtual interviews and hopefully meeting in person at some point down the road.
Well, thank you so much, Dr. Jane. I completely share your sentiment about sharing patients with our uveitis service. I think in fact, this Tuesday, I saw a patient of Dr. Ye's. Dr. Hubbard and Dr. Rao, you're the anchor of pediatric retina for Georgia and surrounding states. ROP training is an important and a unique training experience for our fellows. Can you share with the applicants what they can expect from Emory's Peds Retina training?
Yes, thanks, Joan. We have a very busy pediatric retina service, and we take care of all types of problems. ROP, Coates disease, Stickler syndrome, fever, persistent fetal vasculature, retinoblastoma. And so it's a very rich experience. And I have, I don't know if you can let me share my screen here briefly. I'll show you.
Sure, I'm gonna stop share so you can share yours.
All right, hold on. So I'll just show you an example of a case that we saw not too long ago. So this is a 3-year-old sent in with leukocoria, possible diagnosis of retinoblastoma. You can see the leukocoria on the left side of your screen, and then this fundus photograph showing bullous retinal detachment, and you can see some vascular abnormalities down below. And then looking a little more closely, you look at these vascular abnormalities, and you see they're quite distinctive. You know, the way they've got these light bulb sort of telangiectasias. The angiogram shows a classic pattern. So when you see this and you look at it closely, once you see this a couple times, you know exactly what it is. It's a pattern recognition thing. It's just a matter of seeing it over and over again. And then you know this is not retinoblastoma, it's instead Coates disease. And so we have several different options on treatment. And we like to use laser treatment for this. And we've developed a protocol using yellow laser treatment for this Coates disease. Works very well. And I'll show you a similar a case that was treated with Avastin. This one was thought to be Coates disease, but it turned out to be retinoblastoma. So the last thing you want to do is treat a case like this that turns out to be retinoblastoma with an injection of intravitreal anything, Avastin or anything else. And you can see with these two photographs, these two entities can really look quite a bit alike. You know, on your left here, you see the case of Coates disease with this subretinal exudate. And, you know, classically Coates has a yellow exudate, but sometimes it can be very pale yellow. And then on your right here is a diffuse infiltrating retinoblastoma. And retinoblastoma classically is white in color, but you can see sometimes it can be kind of a yellowish white. So you can't always go by, you know, leukocoria being retinoblastoma, because Coates can cause leukocoria. And even if it looks a little bit yellow, it can still be retinoblastoma. So it's really a pattern recognition thing. And I think you'll get to see a lot of cases like this in our fellowship, so you won't get fooled by distinguishing the difference between these things. And this just shows our laser settings when we're treating these things. We use a long duration painting type of laser to paint those telangiectasias. And you can take a case like this with no injections, no vitrectomy, no buckle, nothing, just with a laser, and get it to flatten out just like this. This is just 3 months after a single laser treatment. Now, this eye is never going to have great vision, but at least you haven't subjected them to a lot of invasive surgery. The retina is reattached. The eye's not going to have neovascular glaucoma, and it's going to do quite fine from a cosmetic standpoint, and they'll have some vision with this eye. So this is the kind of thing, you know, a lot of what we do is pattern recognition, and seeing these things is the key to being able to make the diagnosis, and then learning how to intervene and take care of these pediatric retina conditions, along with all the other things that you've already heard about with uveitis and inherited retinal diseases, and the experience at Grady and the experience at the VA. I mean, I think it makes it so that we've got a really good, well-rounded experience. And Preeti, please say a few words about pediatric retina from your perspective at Emory.
Yeah, so thanks, Baker. I feel very lucky to kind of share the pediatric retina service with Baker. You know, I kind of divide, you know, felt like pediatric retina fellowship into kind of peds light fellowships and then actual pediatric retina. And I do think that our fellowship is very, you know, heavy in terms of, you know, true pediatric retina with the breadth of disease that Baker mentioned. In terms of our, you know, breakdown of pediatric retina with ROP specifically, the fellows have a great opportunity to do ROP both at Emory and at Grady. So at Emory, you know, we at the main campus at the Children's Hospital, you know, we get referrals from basically the entire Southeast. So, you know, in terms of ROP treatment, ranging from laser to anti-VEGF therapy, you know, there's at least, you know, definitely a few cases of treatment almost every week or every other week. At Grady, there's a nice opportunity for the fellows to do ROP screening, autonomously, excuse me, with oversight by myself and Baker. And so it's a great opportunity for fellows to screen ROP babies as well as treat in a controlled setting. So it's a nice way to kind of get your feet wet into pediatric retina and take your retina training up to like that third ultimate level.
Thank you, Dr. Hubbard and Dr. Rao. Here's our ocular oncology team. You see, here's Dr. Hubbard again. This man is everywhere. So he and Dr. Rao, they take care of the pediatric oncology part. And Dr. Jill Wells right here and Dr. Hans Gross-Niklaus, they are the adult oncology team. Unfortunately, they cannot be here tonight to meet you, but you see their faces here. As you know, oncology training is not common for many retina fellowships. We are lucky to have these mentors for the oncology training. The surgical retina fellowship is divided into 2 one-year periods, with the first year leaning towards medical retina training and the second year towards the surgical training. Our medical retina fellowship, which is directed by Dr. Ye and Dr. O'Keefe, is an integral part of our fellowship. As you can see, our surgical and laser numbers are more than plenty for you to feel comfortable with when you graduate. COVID did put a dent in our overall number last year, but our fellows graduated just as strong towards the end and are enjoying their independent practices right now. We do a good mix of cases, ranging from holes and puckers, IOL cases, diabetic cases, to complex RD and challenging pediatric and oncology cases. Here, I just want to make a point that is not all numbers are the same. You may hear some programs have 800 fellow cases, but that may be most holes or puckers. Our numbers reflect the complexity of our surgical cases. Because we are a tertiary referral center, we treat complex diseases that's very difficult and requires longer OR time. And we also allow our fellows with much more hands-on experience. We put a great emphasis on quality and diversity of training. One example is the scleral buckle. It is a much less frequently performed procedure today because it's very difficult to teach because there's not a side scope. However, it is an excellent procedure of choice for certain diseases so that we want our fellows to learn how to do scleral buckle by the time they graduate. And our philosophy is to put patient care first, to work hard, be conscientious, and be prepared. We want to train the next generation of VR surgeons and medical retina specialists. We realize that clinical research is a necessary tool for improvement in patient care. Therefore, we encourage and require our fellow to have research experience. Last but not least, the professionalism is an extremely important part of our training. We expect our fellows to adhere to a professional code of conduct, to have good communication skills, and to share a sense of responsibility. At the end of the training, we want all of you to be well-trained and prepared vitreoretinal specialists for whatever the future career that you desire. We want you to feel comfortable with most cases in clinic and in the OR, and to know where your limits are. We want you to think that the toughest cases are the ones you saw during your fellowship at Emory. We want you to have clinical research experience and to feel comfortable with writing and submitting papers, and to also have teaching and a mentoring experience. This slide shows where our last 5 years fellows are. As you can see, they are all over the country, going all the way from the Southeast to the Northwest. Well, that's it. Thank you for your attention. All of you have accomplished so much in your short career, and we're so very proud of you. We look forward to meeting you virtually on Friday, October the 9th.